I don't have a page of, what is that? Introduction or CV. So I'm just going to introduce myself. I do work in Aster Medcity now. I did my post-graduation from Trivandrum, and a lot of the reading at that time was done there. But my technical skills and formation happened in Vellore and in St. Stephen's Hospital. And I have to say, I did spend some time in England, in Princess Royal Spinal Injury Centre. And I owe it to that centre to have used my freedom to think a little bit more. And some technical bits were taught there too. I currently work in Aster, as I said. We are going to talk mainly about spinal cord injuries today. And the good thing about cord injuries now is that we have very good data available. If not from India, definitely worldwide. There's a fantastic amount of good quality data that is available. So we'll also go through some cord syndromes, some aspects of sensory motor and autonomic paralysis. We'll give some examples. And I would like to say what rehabilitation actually means. A nod to this great man, Sir Ludwig Guttmann, who perhaps was instrumental in really bedding our understanding of spinal cord injuries, almost single-handedly, as in single-handedly in terms of thinking about it. But he had a great team to help him. And all the expertise that now we have in spinal cord injuries, I think we owe it to great people like that. And like Sir Isaac Newton once said, all of us stand on the shoulders of giants. And he is one such. So while in working in England, I had this opportunity to be part of the clinical reference group, which was a group that was formed out of a group called the National Spinal Cord Injury Strategy Board. The clinical reference group had the duty to formulate policies regarding spinal cord injury in the UK, particularly in England as a country within the UK. So there was a large amount of data available for us to look at, and countrywide data showed that most of the cord injuries in England took place at the cervical level. And I just looked at our data. This is data from 2021. I apologize for that. But 2021, about the third year I was here in Aster Medcity, that is our data. We had 58 patients on that year. But you see the majority of the patients have actually come from the cervical group. And there's another big jump in the T6 group. A lot of them were injured because of two-wheeler accidents. You look at the data again, if you add up all those incomplete bits, there's 70% of spinal cord injured in England are now incomplete spinal cord injuries. And we too are veering towards that. Why, in my days in Vellore, we remember most of our patients were complete injuries. It's no longer the case. We have a majority of patients who are coming with incomplete injuries, which is very nice because I think recovery at accident sites have become definitely far better in this country than when I left this place. Age distribution is also very important for us to understand. It used to be that very young people were involved in cord injuries and predominantly males. But that was the case when I went to England. About 20 years later, the modal distribution is around 65 to 69 years, which means that many of our cord injured were very, very old, 80, 90, and so on. And it's not very different now in India, at least in Kerala, where I see a lot of old patients with cord injuries. And we come to cord syndromes. In the cervical cord, this is the most common syndrome that we see. It's a central cord syndrome. It's usually caused by a hyperextension injury in degenerative spondylotic spine. And in this condition, the hands are more affected than the lower limbs. This is important to recognize, and also I can now almost categorically say that all central cord syndromes, in fact all incomplete spinal cord syndromes, come with a Brown-Séquard pattern. We were taught that it was a very rare condition. No, it is not. It's the commonest condition you can actually come across. So this is a classic case in which you get an hyperextension injury. You can see those discs. It's a T2 weighted image. You can see fluid as white, and you can see the discs are all dry because they are black. And once it is dry, it loses its sponginess, its elasticity. So once compressed, it doesn't bounce back to its original size. It starts going backwards. And in a similar fashion, you get ligamentum flavum, which normally is elastic and bends like that when you are young. But when you're old, if you hyperextend, it is rigid and it bends like that. So it buckles and presses on the spinal cord. Classically, this produces a reduction in the blood supply through the anterior spinal artery, and therefore the central cord syndrome. Hemisection of the cord, like I said, is very common. It's when we say hemisection, it's not a hemisection produced by a knife injury always. So in the central cord syndromes, when you get so-called hemisections, you have features of Brown-Séquard syndrome, but you may not get all the features of the Brown-Séquard syndrome. Now, if you have a knife injury, then you could get a classical hemisection, and those are the characteristics of the hemisection. You will have ipsilateral loss. On the side where you had the injury, you will have motor paralysis, along with posterior column paralysis. On the opposite side, you will have loss of temperature and pain. And that is the picture of a patient who actually had a knife injury. You can see the track of the knife, and then one side of the cord being involved. The reason for central cord syndrome to act the way it is because of this. All the fibers of the upper limb, the upper part of the body, are towards the center of the cord as is given here. And when the center of the cord is involved, you tend to affect the upper limbs more than the lower limbs. There are other reasons for that. That's from the blood supply. And you can see the major blood supply to the cord comes from the anterior spinal artery and two posterior spinal arteries. But the anterior spinal artery supplies the anterior 2/3 of the cord. And this shows it much better. And this also brings us to two other types of cord syndromes that are described. Anterior cord syndrome is when the anterior part of the cord is affected fully. You lose all the motor power that is available to you, but you retain your pressure sensations, your joint position sensations, and so on, because your posterior cord is intact. And there is a condition which is called the posterior cord syndrome. Personally, I have not seen one as yet. It's important to know about this one. This is because, often we hear about the artery of Adam Kiewicz. Actually, Adam Kiewicz described about several arteries, of which the T11 one, or anywhere between T10 and T12, you could get a feeder artery which is supposed to be big. When you say big, it is almost like the size of a stem of a safety pin. That's the size of the artery. But that is important because when you have a block there, you can produce significant damage to the cord. About classification, I'm just wondering how much time I should spend on this. The chart is actually quite self-explanatory. It's in detail. It explains it well. On the other side of the chart tells you how to examine and how to classify the cord injury to Asia impairment scales, A, B, C, and D. I just thought if you want me to talk about this, I thought I'll talk about it individually, but I would much rather that you read this. And if there's some postgraduate who wants to discuss this with me, I'm very happy to spend time. So I'm going to run through that. But why do we want to classify this properly? And this is the reason why. Because like I said, we got enough and more data now to confidently say that these are the things that will happen to people with the Asia B, C, D, and D. And depending on age, we can actually predict how much improvement they will have. I mean, we are talking about, 33%. We are talking about 33% of the people with Asia B light touch preservation walking out, not simply recovering a few muscles in order to be able to move them. And this is an important paper, so if you can actually access it, I've given you the way to access it. Please access it and read it. Every postgraduate should know about this. But I really want to also talk about another important aspect of cord injuries. It may not be traumatic, but when people come with pain between the shoulder blades, please don't ignore them. And people come complaining of neck pain, very, very common. Lumbar pain, very common. Why neck pain and lumbar pain? Because neck is the most mobile segment of the spine. So you are likely to have mechanical degenerations and therefore mechanical pains arising out of the neck. And the same is true of the lumbar spine. But when somebody talks about pain between the shoulder blades, please don't go on prescribing them painkillers. That is not the way to do it. If you wait for 2 weeks and beyond that, you should actually investigate them for serious problems. Even last week, there was a 48-year-old man who came to see me in clinic who complained of interscapular pain. So I asked for an X-ray and found out that he had 2 fractures. And they looked like concertina collapses on T8 and T10. So I pointed it out to them and said, look, this is probably the reason why you're having the pain. We need to do your bone density. And lo and behold, this 48-year-old man had osteoporosis in the spine. Of course, we need to make sure, is using here now? No, we talked about 128 differential diagnosis. I only know one other differential diagnosis, which is like you need to rule out cancerous problems. So anyway, the patient was sent, this was ruled out, and we were now thinking about correcting his osteoporotic problems. Okay, but that's the importance of not ignoring interscapular pain. Please do not ignore interscapular pain. So usually pain precedes a collapse of a spine and so on. Therefore, please be sure that you look at it seriously and carefully. Do not go on prescribing painkillers for over 2 weeks. Right, there are some examples of what I have come across in patients with thoracic pain. That is a T5 level AISD. There was a tumor sitting there. This is not necessarily a person with thoracic pain, but one of the interesting patients I came across is a person with multiple neurofibromatosis. You can see that is around this picture. Sorry, do you have a pointer? Oh, this is a pointer, is it? Oh, okay. That is the pelvis. And look at the number of neurofibromatosis tumors that you can see. But he had multiple in the neck also. Fortunately, you see that? He had a AISD tetraplegia. He walked out of the place. Unfortunately, these people come back multiple times because some tumor is grown and it compresses the spine again, cord again. So there's a 70-year-old lady with a T10 level epidural hematoma. A lot of people are put on warfarin to counter atrial fibrillation and so on. But then you should be careful when they come and talk to you about pain between the scapulae or pain anywhere in the spine. You need to investigate them for hematomas that can cause compression of the cord. You can also get aortic dissection. That is a classic case of aortic dissection. And fortunately, again, this is an incomplete cord injury. Aortic dissections that involve the descending aorta can also affect the artery of Adam Kiewicz at around T10 or T12 or T11 and cause paralysis. Fortunately, this was an incomplete paralysis. You need to examine whoever comes to you properly, and this is the general examination in a clinical setting, usually in an emergency setting. And priapism is something that you'll see only in acute onset injuries, but if you get to see a patient with spinal cord injuries, please make sure that you examine the person properly using the Asia charting. So, any lesion above T6 can cause a sympathectomy, so to say, and therefore give rise to a situation where their vascular beds are wide open, especially the splanchnic vascular beds. And what then happens is your BP falls. But like in a hypovolemic shock, the BP fall does not produce an increase in the pulse rate. That is also because of sympathectomy. So this is called a neurogenic shock. You need to be very careful not to overload the person with fluids. It was actually a common problem even in the UK. But fortunately, newer training programs have come in. I have not come across a problem like this, that is overperfusion shock, causing pulmonary edema in India as yet in the last 6 years. But remember, you have low BP and low pulse and warm extremities. That should be differentiated from hypovolemic shock. Now, complications. What are the complications that can come across because of spinal cord injury? You can get acute gastric dilatation in the first 48 hours or 72 hours. Be careful about it. If you have gastric dilatation, that requires an NG tube insertion, and you should be careful also to give them gastroprotection. And that is because stress itself can cause stress ulcers. So gastroprotection and NG tube, if necessary, should be inserted. But in a tetraplegic, when you insert a nasogastric tube, be careful. You can actually stimulate the vagus and produce a cardiac arrest. And these are real problems. If you are doing that, be careful to keep atropine ready with you. Sudden onset breathlessness in a patient with acute spinal cord injury. There are a few things you need to worry about. If the patient is old, make sure that you rule out myocardial infarction. Second is pulmonary embolism, but also you can get a mucus plugging like this particular. This is called a whiteout. One entire lung is being seen blocked with a mucus plug, and once you recognize this with an X-ray like this, as soon as this happens, of course, start oxygen because the person will be breathless, and then get a quick X-ray, and if you see this, turn to the side that is okay and thump him properly. You can actually dislodge the mucus plug, and this is actually 5 minutes after the thumping in the same patient. But the cornerstone of managing patients with tetraplegia for their breathlessness is to make sure that you assist their cough in such a way as to clear their lungs properly. Mechanically, they are unable to clear their lungs because of their abdominal weakness. So if you can do this regularly, you are likely to keep infections away. And CT scans. This is only to show the CT scans give you far greater detail of complications of consolidation that occurs in spinal cord injury. But if you look at the right side here, the way you diagnose consolidation is that you can't see the diaphragmatic outline. On the right side you can't see, on the left side you can. But if you then look at the CT, you can see how this is starting to happen on the left side also. More importantly, we are now understanding a lot more about infections in the chest in spinal cord injury, and we know it is related to the level of the cord injury. The higher the cord injury, the greater the chances of getting chest infections, not simply because of mechanical factors like reduced ciliary movement or poor abdominal strength, but because of the fact that it affects the lymphoid organs and therefore cause lowered immunity. And I'm very happy to elaborate it for people who want to discuss this further. The other complication is DVT, deep vein thrombosis, 80% incidence in people who are not treated with anticoagulation. So as soon as a person comes to you, start anticoagulation. If there are no associated bleeding occurring anywhere else. Supposing you have a concomitant head injury. Yeah, okay. Concomitant head injury, then you can get bleed in the brain and you don't start off with anticoagulation straight away. If it is possible to start anticoagulation, start it on day 1. Usually we use Clexane, 0.6 milligrams once a day as a prophylactic. And we need to be able to switch over to an oral regime as soon as it is possible. You remember, you don't give anything for the first 48 hours to prevent gastric dilatation and complications arising out of that. We've done a study in Sheffield and over a 132 patient sample, we found that in those people who had clinically significant DVTs, it occurred in the second week. The largest number occurred in the second week, so we had a very large spike. And then nothing happened for another 8 weeks, but during the 10th week, we had a smaller spike. After that, we have not really found many incidences of DVT. So, routinely, we do not put anybody on DVT prophylaxis once the 3 months are over, at least in England. So, that is the saddle embolus. And if you get a saddle embolus, of course, it requires emergency treatment. And the first thing you do is to actually recognize it, start on oxygen. If you suspect pulmonary embolism, start the treatment anyway, and then send for investigations. And what you will do is, of course, make sure that your D-dimers are done, and you do an ultrasound or Dopplers to rule out clots in the veins. And if you then suspect that there is a pulmonary embolism, do a CTPA, and you've already put the person on treatment. If there is no problem, no DVT, then discontinue the treatment dose of DVT, anticoagulation. But if you find that there is a embolus, like not always a saddle embolus, there are smaller emboli, you then go and look at the femoral veins and the pelvic veins, and if there are clots sitting there, now we recommend that you put a filter, okay? And you can call the interventional radiologist and put a filter for that. This is about autonomic dysreflexia. I noticed that there's a talk on this, therefore I'm not going to elaborate on that. But only to say that the commonest cause of autonomic dysreflexia is to do with the bladder. So look for bladder problems if you have autonomic dysreflexia. In fact, autonomic dysreflexia, the commonest cause is bladder, bowels, and ingrowing toenails. If you can rule these 3 things out, you have covered 98% of the problems. I'm not going to elaborate on this. Pressure sores. You have to prevent pressure sores. That's the best thing to do instead of trying to treat pressure sores. That is a grade 1 sore. And if you now offload the person from pressure on that, you're not going to have any problems. Once you have crossed grade 1 sore, this is a non-blanching hyperemia of the skin. If you offload now, you will actually save the patient from getting a pressure sore. But if you continue to apply pressure, you will produce a pressure sore, and that can vary from grade 2 to grade 4. And the reason for this is that the capillary vasculature pressure is actually very low. You don't require a great deal of pressure to block off blood supply. So if you're not going to offload, you will get a pressure sore in a grade 1 sore. It can then give rise to things like this. It is terrible. This is the femur sticking out through that. We had this patient with us. We can repair it, but why go for that and then repair it? It's far better to prevent it. It is very expensive anywhere in the world to repair a pressure sore. At the moment in Aster Med City, if you have a pressure sore grade 4, the repair cost will be 8 weeks in a hospital. roughly 8 weeks in the hospital and 8 lakhs. That's not a small sum. You need to be worried about that. So prevent them as much as possible. And to prevent pressure sores, the most important thing is to turn the person. I mean, even the best mattresses in the world cannot actually prevent pressure sores if you don't turn them. The only thing that can prevent pressure sores 100% is a fluidized airbed. That is mighty expensive, and we don't use it willy-nilly even in the West. Because it costs a lot. If you want to buy a bed, it's 50,000 pounds to buy one. To maintain it is very difficult. If you want to rent it, it's about 200 pounds a day. So you don't use that now. I mean, you don't want to actually use that now. But even in a fluidized airbed, turning is essential because you can cause consolidation, retention of fluids in parts of the body, which is not very nice. Therefore, you need to turn them anyway. Spasticity is another problem that can produce complications. So if you can prevent spasticity, you should. If you can't prevent, then treat the spasticity. There are various ways of doing it. The next slide will show it. If you don't, it is actually going to reduce joint movements and malpositioning occurs, contractures, disability, discomfort, all those things occur as a result of pressure sores. One of the best ways to counter production of deformities or occurrence of deformities is to put the patient prone. Not a very popular thing. Anywhere in the West, it's not very popular. I don't know whether you continue to do that in Vellore. It is a very, very good way to, in my opinion, the best way to prevent contractures. If you have spasticity, there are various ways of dealing with it, starting with physical modalities, pharmaceutical agents, tablets. There are things that work on the spinal cord, like baclofen and tizanidine. But also, there are things, relaxants that work on the muscle. Therefore, you should be able to give that. Surgically, if you have global spasticity, then the best way to do that is to have baclofen pump insertions. Some people have spasticity, they develop contractures and they are resistant and non-yielding. In such people, you require surgery to treat the contractures. And this is a patient, this patient after treating the contractures with surgery is like that. So in the acute management of spinal cord injuries, if you can recognize their potential, you can really do a lot. And if you prevent complications and give hope, they do very well. Thank you.